Hi, everybody. This is your week 6 lecture for physical dysfunction. Sorry about the weather. Your homework in relationship to PhysDis will be due the following Monday as normal by 9 a.m. Okay? All right, so let's get started. We are discussing amputations and prosthesis, components, training, and treatment. Megan Taylor will be doing an hour of this lecture as her student lecture, and that date will be determined at a different time. So she will be doing that lecture, however, before your next test so that you will hear her information as well, okay? Here are your learning objectives. Also on this slide, when you look at your notes version, there are terms such as phantom limb pain, phantom limb sensation, etc. So please take a look at the vocabulary with this slide. Okay. So I hope you enjoyed that video. It is truly amazing what people who live with amputations can do if they don't let anything hold them back. So this is in your PowerPoint. You're welcome to link up to the video again and watch it. Every athlete and the little girl and every warrior in it are truly inspirational to me. So very proud to share that video with you. Next slide is your case study. So we will talk about your case study and how we're going to do that due to virtual stuff this week. So we'll talk about that later. So we're just going to skip over this slide. All right, so we're going to move straight into causes and types of amputation. There's prosthetic use and OT intervention are affected by the cause and type of the amputation. Okay, number of limbs, the side that it's on, the person's age, their health status, their residual limb wound bed. So all of that being said, OT, of course, intervention is going to change based on your client, as always. And then we also want to talk about who uses prosthesis. Who's going to want to wear a prosthesis and successfully use it? Someone born without a limb or who loses a limb? Okay, so you want to contemplate that. People born without a limb are used to not having a limb. People who lose a limb tend to want to try a prosthesis. Has a long transradial or a long transhumeral amputation. Okay, so that's the location, and we'll go over those. Loses a leg at 2, 12, 32, or 72 for inches. Loses 2 digits on dominant or non-dominant hand. I think people would want to definitely on their dominant hand. And then loses 1 or both lower extremities. So upper extremity amputation can be caused trauma, or it can be congenital, which means a type of birth defect. And cancer can also cause this, being osteosarcoma or Ewing's sarcoma. So, and we see our little girl here. She was born with her concerns. So that would be a congenital amputation. Lower extremity amputation is usually related to vascular disease and diabetes, as well as trauma. So a big key thing to know for your exam is the discussion about the congenital versus trauma loss of a limb, and that a birth defect that takes place in utero is not considered acquired because it is congenital. You are born with it. Okay. So what type of amputation is not acquired? The answer would be birth defect in utero. All right, let's talk about upper extremity amputation levels, okay? You have shoulder forequarter, okay, which is here, across the chest. You lose the entire arm and shoulder, okay? Shoulder disarticulation, where you still have this part of the shoulder versus here, where it's lost, okay? So down through this area, okay? Then you have short transhumeral, okay, and long transhumeral, okay. Then you have, I'm sorry, that's transradial, and this is your transhumerals, okay. And then you have your wrist dearticulation, which is where you lose your hand, and you have your transmetacarpal, which is where you're going to lose fingers, okay. You will need to know where these are all taking place. So you'll need to know these. And that's transradial, transhumeral, transtibial, which is below the knee. It may be either short or long. Transfemoral, above the knee, may be either short or long. And then the disarticulation is through that joint. Okay. And it may occur at the shoulder, elbow, wrist, hip, or knee, or ankle, but it is through the joint. Okay. With disarticulation, what you need to, another item you need to know for your exam is that it's the complete loss of all muscle structure, okay, of shoulder movement, but scapular movement remains intact, okay? So if you're looking at the shoulder and the shoulder disarticulation amputation, it's a complete loss of all muscle structure, shoulder movement, but scapular movement remains intact, okay? Transhumeral is also going to be on your exam, and it allows for complete shoulder movement. It's the shortest length from hand up, okay? And transmetacarpal allows for full active range of motion, okay, except for proficient hand use. So if you, this is part of your test questions, if you have a transmetacarpal, okay, amputation, you have full active range of motion everywhere else except the finger that's affected and the area that's affected, okay? So that means you lose some hand use. Okay. Psychosocial implications. There will be scenario style questions over psychosocial implications. All right. We spent an entire semester discussing psychosocial mental health and how it can affect people with rehabilitation from a mental health aspect. Now we have the discussion of someone has a physical impairment that causes them to have a psychosocial issue, okay? People have a difficult time adjusting after an amputation, and it can take a toll on their mental health, how they view themselves, what they think the world views them as. So how do these factors all contribute to that? So we've got the cause of the limb loss. Okay, maybe somebody was out in the yard and a tree fell on them and it severed their arm. Okay, or you've watched the video that we talked about and you are submitting your ALOs. Okay, totally different way to lose a limb. So the cause of the limb loss is important. Age, gender, relationship status, hand dominance. If you lose your left arm but your right arm dominant, may not have as much an effect on your life. It'll have a lot, maybe not as much if it was the dominant side. Socioeconomic factors, which is money. Okay, can they afford what they need for someone who needs a prosthesis and care of a residual limb. Cultures value beliefs and spirituality. Culture plays a key role as some cultures look poorly upon people with amputations. Employment status: can you work? Can you not work? Did you lose your job because you had an amputation because you were out for a while? Can you get it back? Can you not? And then your physical environment. Physical environment has to be adapted quite often, especially for your below the knee amputations and your AKAs, especially bilateral. So lots of physical environment changes because they're unable to reach the back of the top third half of the cabinet and whatnot. Okay. Let's just be prepared to be able to discuss those. And our job is to help them adapt to their functional tasks, ADLs, IADLs, leisure activities within their new normal, okay? Because we want them to participate in all the occupations that they can and that they want to. Sleep hygiene is also very important with psychosocial implications, and we will discuss this again later in another chapter. So it's very important that you know that sleep hygiene is of concern for someone post-operatively, and that can also take a psychosocial toll on someone's health. Pain and sensory issues. Okay, so imagine if you woke up one morning feeling like you had a third arm. It itches, a vice is squeezing the fingers. You know you don't have a third arm, but that doesn't stop the feelings. You still feel that hand and arm just itching, okay? And then it's like, it's tight, okay? How would this affect school, work, home life, driving? Having a third arm that you don't have, how would it affect your life? What is the difference between phantom limb pain and phantom limb sensation? Okay, so phantom limb pain is perceived pain coming from an amputated body part. Okay, this usually occurs with trauma. People who go in planning to have an amputation due to vascular disease or diabetes tend to not have as much phantom pain as others. But if your limb is taken in a car accident or whatnot, there tends to be lots of pain associated with the limb that is removed, that it hurts or whatnot. And that is called phantom limb pain because it is perceived pain, because there is no pain because you don't have that arm or that leg, okay? Phantom limb sensation is going to be things like itching and touching a specific part of the whole limb or part of the limb that was amputated, okay? So where phantom limb pain is global on that limb and it's excruciating pain, the sensation is like, oh, well, somebody's, you know, I've got an itch on my ankle that I need to scratch, but you don't have that ankle anymore, okay? All right, so you do need to know phantom pain or sensations. That is a test question, and what they are in their differences and likenesses, okay? And you also need to know how we treat it as OTAs. A lot of times we make a referral for medication. Okay, that's number one. We also can use TENS units. And we also use mirror therapy. Okay, so those are the three areas that OTA can help with. And we do encourage and promote and discuss with doctors types of medication to be used, whether that's pain medication for an actual limb that is hurting, or if we look at psychosocial medications with the doctor and have those discussions. So medication, TENS units, and mirror therapy, okay? Mirror therapy is very, very neat, and I know that Megan will be going over that in her presentation as well, so I will leave that to her for now. There's also changes in sensation. They may normally have perceived hot and cold, and now they've reversed them or whatnot, okay? So we perceive how they perceive their environment, balance, and function with ADLs and IADLs also plays into pain and sensory issues, okay? So we've discussed how it would work, be different in our lives, in our clients' lives if there was an amputation, the difference between phantom limb pain and phantom limb sensation, and also the 3 different techniques to utilize in OT to address them, which were medication, TENS, and mirror therapy. There are many different types of prosthesis. Again, I know Megan Taylor will be covering some of this. We'll go over a broad view here. The field of prosthetics has come a long way since Pirates' wooden legs, but hooks are still used today. We do differentiate between the following. Prosthesis is a passive, body-powered, myoelectric, and hybrid types. Then you have terminal devices, okay? This is a cosmetic hand, a prehensile hand, a hook, and activity-specific styles of hands. And they can be voluntary opening or voluntary closing, okay? So, all prostheses have the following components. They have a socket and a suspension system, okay? A terminal device, which is the most distal component of the prosthesis, and that acts as the hand. It can disconnect at the wrist or be interchanged with various types of hands or hooks, depending on the function needed. Cost, huge concern for people. They vary greatly based on the type of prosthesis, especially with myoelectric being more costly. The higher the tech, the higher the cost. And then we have passive function prosthesis. They're similar in appearance to no affected limb and is passive in nature. It provides no grasping, but can be used and assist to stabilize. So if this is a passive function prosthesis, it looks okay, but it can't pick anything up. It would only help hold something. This would have to be my active hand to scoop something up against it, okay? Let's see here. All right, so the next area is the body-powered prosthesis, which has a harnessing system and uses the client's gross body movements to control an execution on a cable, okay? And we have myoelectric prosthesis, which has electronic motors, is battery-powered, okay? And the client controls the prosthesis through the use of myoelectric signals to electrodes within the inner surface of the prosthetic socket. It is heavier and repair process is more complicated and time-consuming, and I'm sure costly. So it is also susceptible to moisture. You have hybrid prosthesis and then activity-specific prosthesis as well. And those activity-specific prostheses are used to perform a specific task or activity, and they're available in a wide amount of options for you. So here is a Bowen cable control system. Okay, so you can see how it's supported along the back here in hooks. Okay, and then here's your cable coming down. You can see it again here. Okay, and that cable comes around here to the forearm, right? And we have another here. So that can cause the arm to pull up. Okay. So there you can see how it works again in a sketch. So again, here's that harness over the tricep area and the lat dorsi, rhomboids. Okay, and they're calling it a ring harness, makes sense. And then you come down here to the cuff along the triceps. Cable comes all the way down to here. This plastic part is the cable housing, which you can see here. Okay. All right, and your control cable is your mechanical hook. Here are some examples of terminal devices and activity-specific items. This must be really cool for a kid to have, that you can completely control your hand and arm and do what you want to do, and it be neon green like sports heroes or something. And then you have pitching hands for baseballs and softballs. This is a basketball flat hand. Okay. And then we have how each grip and pinch is done. Okay, so you have your platform, your whole hand point, got your hooks. Okay, do lateral pinching. You do tip to tip to hold something. Tripod, which is 3 hands, right? Curveball. Then you have spherical, which is for a ball. You have cylindrical to wrap around, say, a bottle. Okay. These are other terminal hands. Okay. This is a cosmetic hand. You've got various hooks for various activities. Okay. And then another type of robotic hand. Okay. These are lower extremity prosthesis. So this is a below the knee, okay, BKA, the terminal foot. And then this obviously is hip. These are different types of hip ones. And this is a full, so this is if you've had an above the knee, okay? So this is your new knee, and then this secures onto the hip, okay? This is your new hip if you have had your hip amputated down, okay? One of the things about all of these here, and especially here, which is very important for your test to know about terminal devices, okay? People have more than one, and they have a need for more than one, okay? So be prepared that your clients may need 4 of these, okay? They may need the hook is what we consider for more manual labor, and you need to know that for the rest of your life and on your test. And then the cosmetic for something more formal, okay? So this may be working on the docks, okay? Or working on a boat, on a crabfish, fishing boat or whatever. And then this may be for the heart ball for the American Cancer Society, okay? So that you need to know for your test. You do have scenario style questions built around hooks and cosmetic hands. Okay. So phase 1, okay, what is the role of OT in limb care, or residual limb in phase 1? Wound management is key, okay? A lot of times people have had a amputation because of poor wound healing. And that is something you need to be very aware of. Again, wound healing issues do cause amputations. So you would focus on wound management, skin inspection / skin care. Let me say those again. You need to know them. Skin inspection, skin care. Okay, scenario style question right there. And then we have immediate post-operative prosthesis and then early post-operative prosthesis, okay? Sometimes doctors want something immediately on a residual limb so that it feels and represents a prosthesis for a client. And then you have early post-operative prosthesis, which may come, you know, a week or 2 later. Again, skin care, limb shrinking and shaping. There is an entire process for this where you wrap the residual limb in a very specific pattern, making these little arrows, little V's, and that will help shrink that limb and reduce edema, and will also shape the limb and keep it in a normal, elongated oval that will fit more comfortably into a full prosthesis later. And then desensitization, that freshly healed wound and that soft baby skin that has never borne weight is going to be bearing weight in a totally different, in a new component, in the bones in new ways. So there's going to be lots of desensitization so that we can reduce pain and tingling. Okay, phase 2. Okay, we want to increase general endurance and stamina. Okay, again, this is pre-prosthetic. And then limb strengthening and range of motion, and participation in ADLs. Okay, we want the use of affected and unaffected limbs. We want those motions to start coming back. The training on adaptive equipment, which we are great at for ADLs, okay? If you're wearing a hook hand in the future, but you have none now and you want to put on socks, it gets hard, okay? Education and training. Education of things is so important, and then the re-education of other various items that they're so used to doing a certain way. You can do one-handed and cross-dominance training. So one-handed training would be how to put on a sock with one hand, okay? And let's say that's your right hand and you're right-handed. It's going to be easier to put that on with your dominant hand versus your non-dominant hand, okay? Now, if you've lost that dominant hand and you want to put a sock on, you have to figure out how to do cross-dominant. This becomes your dominant hand now. So you have to relearn a dominant hand to reach with, okay? All right. And then myocyte testing to determine upper extremity limb myoelectron prosthesis usage. And that is just a way to test and train the limb for prosthetic usage. All right, number 3, prosthetic training, which is everybody considers the most fun part for some reason. And it can be, don't get me wrong. But the prep work is so beneficial to get to phase 3. Every step is important, so we don't want to lose sight of that. It is now time to learn how to don and doff a prosthesis, and this can take quite a bit of time, okay? And then control training for elbows, wrists, and the terminal devices of your body-powered and myoelectric prosthesis. So they have to learn how to utilize that. Proportional control is going to be about tension and force. ADL activity using affected upper extremity as an assist. So, like we were talking about earlier, using a residual limb, okay, to push against to lift something up, okay, so that we can pick up our socks, we can pick up our shoe or our shirt or our hairbrush. ADL activity with lower extremity prosthesis and mobility device. So we have to get that leg, lower extremity prosthesis donned and safely attached, and then figure out how we're going to do our ADLs and IADLs with a new leg or foot or whatnot. Okay. For the body-powered prosthesis right here, what would be something incredibly difficult that they have to do as far as an IADL? And it happens in our kitchen. Give you a second to think about it. It has to do with groceries and where we place them. It would be very hard for someone to place groceries in the upper shelving if they've had a body-powered prosthesis, okay? It's going to be easier for them to put something at waist height or right in front of their chest, okay? So that is a scenario-style question on your test. And then, and it's just because things that are close by are easier, okay? We also, for such as our body-powered and myoelectric prosthesis, for sure, we want to help the client avoid crushing things. They have to learn force control, which is the proportional control piece here, okay? So we want them to avoid crushing things. What is something that we all love to eat, maybe while watching the Super Bowl, that could crush easily? You said it, a chip. Okay, so you have to learn to grade, they have to learn to grade the muscle contractions and control that from the body powered and the myoelectrical, so that when they do pick up a chip, they don't, they go like this, and they have that proportional control, okay? Now, if they were picking up a phone, they'd need more movement and more strength versus what you need for a chip, okay? So again, it's all about crushing, not crushing objects, okay? So you'd have to work on grading up and grading down sizes and weights, okay? 4, okay, advanced prosthetic use regarding, okay, OT. Clients should be independent with don and doff. They should tolerate wearing it during the course of the whole day, and they should be able to operate basic controls of prosthesis easily. The goal for the OTA is to train, Okay, surprise, surprise, client, and incorporating the prosthesis effectively during, again, surprise, ADL, IADLs, work, leisure activities, play, etc. So pulling everything in, again, from your OTPF. Okay, this is when the clients really start to feel empowered and they're back to themselves and that they can survive. Okay. Technology and trends in treatment. It's always changing, it's always challenging, and it's always exciting when something new comes out. Mirror therapy, I brought up earlier, is where you place the limb that is intact in front of a mirror and have the client look at it because it is a reflection of the limb that is gone. And if they can see that their limb is there, they quit having pain, they quit having phantom sensations, and so forth. And Megan, again, is going to talk about that, I believe, a little more in depth. Target muscle reinnervation, okay? That is all about working in a very specific location to make things work again, okay? Such as body-powered prosthesis. And then we have the components of computerized lower extremity prosthesis. Almost like AI, they have microchips in them, and it talks to the brain and back and forth, and you just want to move forward, and it just walks you forward like a normal limb. So that does exist. There are foot and knee are two components with computer-assisted technology. It allows for dorsiflexion and quicker adjustment of the knees to allow for smoother ambulation and mobility. So anyway, oh yeah, and the target muscle reinnervation all has to do with nerves, okay? And using those residual nerves from the amputated limb and transferring them to the remaining muscles that have not been biomechanically a concern, not been biomechanically functional since the amputation. All right, so now we're gonna watch some more videos, okay? So I hope you've got to see that first video. Okay, here we go, open link. So there's where your chip comes in. If you notice, she also has bilateral lower extremity amputations as well.
Pictures in the right spot? Yep, they're super easy. Awesome. Oh, yeah. Feel solid when it's up here and bent back. It's not gonna fall off you, right? Yep. Okay. Not even close. Nice. It's comfortable. Okay. See how that feels. Good. Yeah, that's better. Better. Awesome. Yeah, that's more like it. Love it. Me too. Oh yeah, oh yeah. Good angle. Oh yeah, lovely. A little toasty up there. And holding it behind your head is staying on and doing the right thing. Oh yeah, oh my god. Awesome. Not coming off. Not coming off. That's great. Sweet.
All right. Next one is coming up.
I was rolling back to my truck in a parking lot, and all of a sudden I just hear, "Hey, hey!" And I look over, I see this giant Spartan dude running over at me, and I'm thinking, oh my God, you're gonna get robbed, Brian. You're gonna get robbed.
Brian looked rough, and I just felt like I needed to stop him. So I slammed on my brakes, whipped it next to him, and I jumped out of the car.
And he's just like, "Hey, I'm David Labor, retired NFL player. What happened?" This is Buckshot. He was one of the IED detector dogs our unit had. It was April 18th, 2011. I'm walking in the boot prints of the men in front of me, and I'm like, all right, Buckshot, we're going to jump. And right as I push it off with my right foot, my left foot's off the ground, and kaboom. And everything goes black from all the smoke and dirt flying in the air. I've had over 30 surgeries. I can't even describe how much that stuff hurt. And you go and you tell them, hey, this still hurts. And they're like, well, I think you're abusing your meds. So I'm like, okay, well, I'm going to go buy heroin.
Time when I stopped in that parking lot, severely addicted to heroin, just got out of a second detox, and he was going to bed every single night next to his body. He felt like he couldn't be the Marine that he was. He left our country to go serve. He was broken. Completely broken. A place that I was familiar with. I told him I used to play football. I had a gym downtown, and I'd love it if he joined. The following morning, he showed up, and we trained. And we started to explore different things, the way he could do things. For the next 3 months, he came every day. So we just hit it off. I watched the life come back to his eyes.
We just experimented with all different kinds of exercises, and from there, we just built a program around it. After going there regularly, getting stronger, getting healthier, my body pain decreased tremendously. My confidence levels changed. It all became a lot more feasible. Like, man, yeah, this is, I can do this. This isn't possible.
Pick number 252. Last pick in the 2008 draft, making the Mr. Irrelevant. It was the St. Louis Rams. Selected me that last pick and started my rookie year. 2011, I suffered a traumatic shoulder injury, and it's led to a very aggressive pain medication addiction. Started with prescriptions. It quickly manifested itself, and it was anything but dealing with pain. It was the first time in my life I had to look myself in the mirror and ask, who's David without football? It just took a year to rehabilitate my mind and my body. So I said, well, what if we started a gym in Texas? So we moved here. And I launched the Performance Ball, training for elite athletes. I was having success, man. NFL athletes, Olympic athletes, making good money, finding the groove, and then it all changed. Staff Sergeant Travis Mills. He's one of 5 living veteran quadruple amputees. He's blown up, serving our great country in Afghanistan, stepped on IED, lost all of his limbs. I was way across the room, and I saw him walk in, and I was just drawn to him. And I looked at him, and I said, when was the last time you worked out? He looked at me and looked down at his prosthetics and said, I'm sorry, I don't want to make you feel like an idiot, but I don't have arms and legs. I said, Travis, I want to train you. And he said, well, do you have any experience? And the first day we trained, I asked him, I said, what are you most afraid of? He said, well, remember, no arms, no legs, gravity wins, so falling. Then I realized, wait a second, if Travis is in this position that he can't really go to a typical gym. I said, wow, all of these people, veterans, civilians, there's people with physical disabilities, they've sort of been sidelined. They fall into the rehabilitation process, but eventually insurance ran out, cash ran out. Where do they go, right? Where do they go to be a part of a collective group that has this community, this ability to push each other? Once they graduate this 9-week course, they continue to train as alumni. They recognize that they have this ability to train new people like them.
All the world-class medical care out there, great prosthetics. Frequently, there isn't a kick in the ass, something that just pushes you to get going. You know, something like that would never show up in hospital rehab. There's no tire flips, there's no sled hammers, there's no sled pulls, none of that stuff. You don't do medicine balls, slams.
They make you stronger. They instill same confidence, self-worth back into you. Not just that, they're giving you something to do, a place to be, a little sense of community with everybody. David's program, it's invaluable.
Strong beard. Strong beard.
Moving to a third one.
That face that is usually covered by our phone has finally made an appearance. That face wouldn't be doing that if you weren't staying at a Virgo lake house. Your together awaits. Find it with Virgo.
In our morning rounds, reaching for the future, a North Carolina college student created prosthetic hands for kids. They cost a lot less than regular models. Here's the amazing part. He did it using a 3D printer. Anna Warner shows us how the invention dramatically improved life for one little boy. Ask first grader Holden more on how his new hand works, and he'll be happy to demonstrate.
When I bend my hand in like this, say close. When I bend it this, no.
At 7 years old, he's become an expert on the workings of this novel device made out of plastic for roughly $20.
It's an amazing $20.
It's an amazing $20.
And normally the materials cost about like $1,000.
He's right. Children like Holden, born without hands or fingers. In his case, the fingers on his left hand often require custom prosthetic replacements costing
wrist in, the fingers close. When he moves his wrist out,
Tendonesis.
So they actually do have grip strength.
yes.
His goal, for Holden to be able to do things the rest of us take for granted.
Nice. Be able to eat dinner while holding, you know, a knife and a fork at the same time. Be able to grab onto his scooter and bike with 2 hands. Maybe even, you know, swing a baseball bat and get it that strong enough. I don't want him to be limited by condition that he was born with.
So this isn't just about a hand.
No, no. It's about enabling him to do anything that he wants to do.
Needs to be tested. Holden's parents believe the impact could be even more profound.
He's less likely to be underestimated when he has a device like that. So people won't look at him and go, you can't do that.
There are times when, he doesn't necessarily like the kids to ask him about his hand. And because the 3D printed hand is so cool, I think that gives him just the confidence to talk about his hand, which I love. And the payoff for this amateur designer, when he picked up a cup, you were able to say to yourself, hey, this worked.
Yes, yes,
That had to be a great moment.
yes. It's nice to see it all pay off.
Powell has now started a crowdfunding campaign to raise money so other kids can get the device.
Well, I'm actually really happy because I think it's true that once I get the best hands will make more like it for those kids, so then they'll have the best kind of hand too.
11 more children are already waiting for their new hands. For CBS This Morning, Anna Werner, Chapel Hill, Carolina.
And one more.
I know I can be what I want to be. If I work hard at it, I know I can. I know I can be what I want to be. Be what I want to be. If I work hard at it, if I work hard at it, I'll be where I want to be. I'll be where I want to be.
Boys and girls, listen up. You can be anything in the world. And God we trust, an architect, doctor, maybe an actress. But nothing comes easy. It takes much practice. Like I met a woman who's becoming a star. She was very beautiful, leaving people in awe. I know I can.
I know I can
Be what I wanna be.
be what I want to be.
If I work hard at it,
If I work hard at it,
I'll be where I wanna be.
I'll be where I want to be. I know I can. I know I can be what I want to be. Be what I want to be. If I work hard at it, if I work hard at it, I'll be where I want to be. I'll be where I want to be.
So those are our 4 videos, and you can see how technology has changed and grown and is continuing to do those things and be better for our people living with amputation. All right, knowledge assessment. So in order, you need to be able to list what is closest to the skin. It's going to start with the shrinker, which is a neoprene rubbery, it's neoprene, a neoprene residual limb sock, basically. About that thick, and it rolls up and rolls down because it's neoprene and can be wiped off. And then we put on our socket, okay? And then we would put on the limb and then socks, okay? Well, and you could, let me see here for a second. Okay, I was saying sock of the wrong word, different sock, sorry. You would do shrinker, okay? Sock, shrinker, socket. Yeah, sock, shrinker, socket. Okay, because sock is a very thin gauze-like sock for the residual limb. Then you put on your shrinker, which you don't want the neoprene directly on your skin, and then the socket. Sorry about that. Wasn't thinking right. Okay, you need to be able to list these in order for your exam from longest limb length to shortest. All right, and your quiz is going to be, it has no password. It is open for you to take. The due date is listed, and you will just submit it like normally through Blackboard, okay? All right, now let's talk. Let's look at the quiz real quick, see if there's anything I want to review with you. Basic problem areas focused by someone who's lost a limb, phantom pain and sensations, decreased social interactions and changes in body image, all back to that psychosocial of self, and then decreased strength and coordination in unaffected non-dominant side, which we touched on loosely. Okay, so should be that. All right, so let's get out of PowerPoint. And we are going to look at your case study. Okay. Week 6 case study. All right, this is about Kevin, diagnosis of left AKA related to diabetes mellitus, 11 weeks post-op, okay? And he's at a sniff from Veterans Hospital. He also diagnosis of stage 2 sacral decubiti, downgraded from a stage 3 upon admission to hospital, okay? So he's got some skin issues, okay? Please read through his history, his prior level of function. Here's his OT eval and bed mobility information like we normally do in class. Mark that up for occupational profile, what you think short-term and long-term goals would be, okay? Then you will come down here, ignore that due date, please. You'll come down here and write a complete problems list, okay? It's 12 of them, bottom up, top down, okay? Prioritize the top 10 problems. You're going to write your COAST goals and what obstacles you see. And don't just write one word down for me. Give me something full here. What strengths do you feel Kevin can capitalize on to meet his goal? Same thing. Make sure you're giving me enough information on 4 and 5. Okay. And you will upload that to Blackboard. Okay. And let's go to that screen for you and I'll show you what that looks like. Okay. Right beneath the case study, okay, this symbol means you can submit. This is where you'll turn in your case study assignment as we are not in the classroom due to weather. It is due Monday the 22nd by 9 a.m., okay, just like we would do our homework, okay. There's your chapter guide for you to do. Here is your quiz due by Monday the 22nd at 9 a.m., okay. So don't wait until 8:15 to log in just in case you have computer issues after possible power outages, okay? All right, and here is a really cool pic. As you know, I like to show a picture with our phys dis lectures with a biomechanical exercise, okay, for an amputation client. So that is phys dis for week 6. And I will be back with management. Talk to you later.